Before we toast the end of the conference, we have our final educational sections. And I would like to introduce our moderators and speakers, Dr. Cynthia Alcon. Dr. Alcon is an anesthesiologist at the Ottawa Hospital and assistant professor in the Faculty of Medicine at the University of Ottawa. She completed anesthesiologist residency at Dalhousie University and completed a perioperative medicine fellowship at the University of College London Hospital with an MSc in perioperative medicine. And her area of interest including perioperative therapies, virtual post-surgical care, and healthcare leadership. She was the site chief for the Department of Anesthesiology and Pain Medicine at the University of Ottawa, and currently serves as the chair of the Canadian Anesthesiologist Society Hospital Chief of Anesthesia Sections. And welcome, Dr. Alcon.
Right. So hello. So we'll actually be presenting this talk together. So I'll take a minute to introduce my colleague and partner in crime, Dr. Mateen Razi. Mateen and I have been working together on the Hospital Chiefs of Anesthesia section for the last 3 years. He's me in the chair capacity, him in the vice chair capacity. We've certainly learned a lot from each other. He is the provincial head of anesthesiology for the province of Saskatchewan. He's a pediatric anesthesiologist in Saskatoon, and he's also the current chair of ACUDA. So I think our experience working together between his experience in ACUDA and me as the representative for hospital chiefs of anesthesia across the country really sets us up to present this talk, and we were thrilled to receive an invitation to present the closing symposium. So thank you everybody for attending both virtually and in person. A few disclosures. I have nothing to disclose. Dr. Razi does receive consulting fees for Royal College International. And our plan today is to talk about traditional anesthesia care provider models that exist in Canada and also in countries across the world, the various approaches that are used to support anesthesiologists in doing their work, and the different types of innovation that are happening in our country and in other countries to provide anesthesia care, anesthesia support, and improve surgical outcomes for our perioperative patients. And I must say, we both learned a lot preparing for this talk. We've spoken to leaders from other countries who are leading some of these initiatives. It's been really eye-opening. This is a map that I all encourage you to go have a look at if you have a few hours to kill during a long case. I certainly spent a lot of time in it. It is the WFSA workforce map. And it looks at anesthesia resources in all the countries that have available data, both for physician and non-physician anesthesia providers. And there are some gaps, but it's actually a really fascinating resource. So for reference, in Canada, we have 9.5 physician anesthesiologists for every 100,000 Canadians. And if you look at all of the other countries, and when you hover over them on the actual site, you'll get a lot more information than I'm going to talk about today. So in other countries who have either no non-physician providers or very few, other countries, Australia has 20.6 physician anesthesiologists for every 100,000. The UK has 15, Germany has 37, and Russia has 27. If you look at other countries who also have non-physician providers in addition to anesthesia, the US has 15.8, and they have an equal number of non-physician providers, most of whom are nurse anesthetists. France has 17. They also have an equal number of nurse anesthetists. Norway has 20, and they have double the number of non-physician anesthesia providers, something we'll talk about later. Sweden has 18.6 with 2.5 times non-anesthesia providers, and China has 6 with a reduced number of non-anesthesia providers. We don't have that data easily accessible. So the message that I get from here is that we actually have a very low number of physician anesthesiologists providing care compared to many other countries. And we do not have any non-physician anesthesia providers, which really is quite stark when you look at it in numbers like this. But I'll hand it over to Mateen.
Okay, sounds good. So the mic is working okay. So what we're going to do is Sylvie and I are going to tag team a little bit. This is going to be a spectator sport of sorts. We'll go at each other a little bit, go at the audience, and let's have your participation in the QA session that's going to follow. It's going to be really important to hear from people, what they're thinking. Our objective, you saw the objectives there, but our overarching goal is to provoke a conversation and to present information. How you synthesize it, how you approach all this information in your different capacities as leaders is up to all of us to integrate, talk about, and if need be, implement changes. So let's start with the traditional models in the US. This is a system that I trained in. So I have extensive experience with that system, and I still have many friends who keep me updated on what is happening in the US. The CRNA model is now pretty well established, so it's not an innovation anymore. What is the coverage ratio that's happening? People generally quote a figure of 1 to 4, but it's safe to say that nobody really knows. Even up to 1 to 7 has been reported. There's some legal precedent along those lines of troubles that people run into. So we'll talk a little bit more about that. Let this be a bit of an overview. The specialist physicians who are providing service are board certified, and there are foreign trained specialists, international med grads as well, who are part of the US system, especially in rural area service provision. CRNAs and IMG physicians make up the major component of rural service provision in the US. Anesthesiology residents, if you don't know the US system, there's the base year of training, then 3 years of categorical anesthesia training. And the CA2, that's a second year of categorical anesthesia training onwards. There is considerable variation in how rooms are staffed, and pretty much from an HR provision perspective, CA2 onwards are being subject to a 1 to 2 supervision model. Then we have the anesthesiology fellows, which are common to, or equivalent to, I would say, fellows in Canada as well, and then the CRNAs. We'll go into the next slide. I think you might, yeah. Okay, maybe they got ripped around a little bit, but let's talk about this one. So what you'll see, ignore the designations there, NDF and the NPPES. So those are basically databases. Those are two prominent databases that are used to designate how many physicians or providers in any capacity there might be in the US. The commonality is the increasing trajectory, the rise in the numbers. So these, if you look to the bottom right, these are total anesthesia professionals, anesthesiologists, MDs, nurses, anesthetists, and certified anesthesiology assistants. If you don't know what that category is, I'll be dealing with that a little bit later, but keep it in mind that these three combined, if you look at the NPPES database, that's going from 90,000 over a 12-year period in 2012 up to 2024, that's gone up to 140,000. The same trajectory applies to the NDF database as well. So there's lots of providers. Let me quickly, in fact, I'll do that later. Let's go with the next slide.
The other thing to mention is that there's almost an equal number of non-physician to physician. There's about 40 to 45,000 in each category.
Yeah,
half and half.
I was going to go into that later, but good.
Sorry.
No, all good. Okay.
There we are.
Okay. So CRNAs. So where are they? What are they doing? What are their basic training? And how is that model evolved in the US? So these are typically nurses, registered nurses, who have acute care experience of some sorts. They're either from the ICU or the ER. The training program is a 2-year program. And one thing you need to realize is you may not hear consistent terminology. So when you go to the States, some nurses will say they are Dr. so-and-so, okay, although they are CRNAs. So that is not a PhD person, that is not an MD person, that is somebody who has received a doctorate of nursing practice. So that's the one qualifier that's kind of important to remember. Now, wherever you are in the US, the model overwhelmingly still is CRNAs are supervised by MD anesthesiologists. There are opt-out states. Now, these are the states led by California, I think, where independent practice is allowed for CRNA practitioners. They do not officially have to be under the umbrella and the supervision of an MD anesthesiologist. Having said that, even in those states, it's pretty much an MD-led model. The difference from the other models that you will hear about later is that this model has been highly contentious. There's been a lot of going back and forth, bickering, fighting. One commentator compared it to a messy divorce where people are just going at each other. And you look at the literature, kind of reflects that as well. And maybe you just keep that in mind, the way the model has evolved in the US and what we can do to learn from that. The Anesthesiology Society, American Society of Anesthesiologists, ASA, is the body for the MD anesthesiologists, and the ANA, or AANA, is the CRNA practice body. So the ASA's position is that anesthesia provision is a physician-led, team-based effort that includes CRNAs and CAAs as well. The position of the AANA, officially stated, is that they are independent. They want independent practice for CRNAs everywhere in the US, and they want equal pay. So just to give a cost comparison in mind, the pay for, average pay for anesthesiologists, I shouldn't say average, maybe median, is $500,000 or thereabouts. And nurses, CRNAs, are earning about half of that. So give or take. The care outcomes based on literature, now this is often a question asked, who delivers better care? Now it depends on what literature you look at. The only really balanced literature that I found was a Cochrane collaborative review, and their conclusion was it cannot be determined based on current evidence if there's a difference in care provision. And when you look at the literature often cited by the CRNA side of things, typically by AANA, the 4 studies that came to mind, out of those 3 were actually funded by AANA. When you look at the literature that's on the MD side, then the 3 studies that are more robust, one of those was funded by ASA. So there is bias inherent in the literatures that we have. Next, please. The certified anesthesiology assistants. This is the innovation. So who are these people? These are not CRNAs. These are not nurses or physicians. They're actually, we'll come to where the pool is coming from, but they are the most rapidly expanding element in the non-physician anesthesia provider cohort in the US. And this is a model that's been collaboratively developed with the MD anesthesiologists, and there is little to no contention as far as I can tell. In speaking with Sylvia and I spoke with multiple people, and people who are in the programs and leading these are the CAAs themselves. So they're very happy to be in a model that is physician-led, to be part of a team, and to work collaboratively. Now that is a very different development compared to the CRNA model. There are 22 programs that train these CAAs, and they're interchangeable with CRNAs as far as their basic training is concerned, as far as their scope of practice is concerned. And the average starting salary is pretty much the same as CRNAs. The next slide, please. So where are these folks coming from? So the typical intake that started is somebody who would be actually considering going to med school. So they are master's level people with that scope of training. And if you don't happen to get into med school, your plans change, this has become an extremely attractive option for individuals looking for a career that is clinical. So the Master's of Science in Anesthesia is a 2-year program. First year is 50% didactic and clinical, half and half. Second year is a rotating clinical part, and it's pretty much the same candidate pool. They take the MCAT, there's a 3.8 GPA average, and as we mentioned, it's the same pool pretty much. And the next slide, please. How many of these are there? Okay, so this will show you an increase in the trajectory of production. Again, this is a 12-year database, so they're starting from 2012 up to 2024. So what are some of the numbers out there of the snapshot? We took a snapshot in time in the US population right now of providers. We have about 40,000 physician anesthesiologists providing service. We have about 45,000 CRNAs providing service. So if you take the figure of 40,000 physicians providing service, you draw it by scale to Canada, it's roughly comparable. So 1/10 the population, 1/10 the providers. But what we don't have is the other cohorts in there. So we don't have the 45,000 CRNAs providing service or the 4,000 CAAs providing service, and that's a rapidly expanding pool. When we spoke with Shane Angus, one of the key figures He was a CAA himself. So he gave us that data that there's current production is at 600 grads per year, and they're expected by 2027 to go to a production of 1,000 grads per year. So it's a very rapidly expanding field. Okay, next one, please. Okay, changes in the number of certified anesthesiologists or assistants and nurse anesthetists. Both trajectories you can see. The purpose of this slide is to show you that if future projections can be mapped out from here, you'll see that the blue line there is CRNA, and the green line is the certified anesthesiologist assistants. They are diverging. So basically what's happening is the trajectory of production in the CAA category is departing from the increased projections in the CRNA. So keep that in mind when we talk about some future trends and some other practice models. Next one, please. Let's sum it up. The independent non-physician CRNA model, contentious. 19 states say that CRNAs you can practice independently. It's definitely divisive. The certified anesthesiology assistant model, CAA, rapid evolution, and it's gaining a lot of traction. So non-physician to physician providers, people say 1-to-1 or 1-to-2 or 1-to-4, but there are ample innuendos, if not proven situations, of 1-to-7 or even beyond models. And the smaller you go in states, the more variation you find. There have been a lot of court precedents, legal edicts issued in saying that anything beyond 1-to-4, you're setting yourself up for risk. Okay. But 1-to-4 seems to have gained traction. And who funds this? This is very unlike Canada. So the funding is a discussion all unto itself. It's the hospitals, the practice groups, it's the federal government, it's the state government that's all coming in to fund different sorts of models. So we can perhaps have that discussion at a later time. Next slide, please.
I think that's it.
Okay, and over to you, I think.
I think one of the interesting things about that model is that these people are certified, they're regulated by physicians. Like it's a physician assistant, a physician associate for anesthesia. That's the model that they've created. So they're licensed by physicians, through physicians, they're involved in the teaching. Whereas the CRNA model, they're licensed through the College of Nursing, right? So that's the big difference. I think they've created a position of people who are us. So on that note, we'll move across to a different country, which is a country that I did some of my training in. I spent a year in the UK in 2017, 2018 at UCLH. And it's they have also approached, they have similar problems than we do from a HR standpoint and have come up with some interesting approaches. So I think one of the things we can learn from the UK is how they've brought in international physicians on a national approach and built pathways for people to be able to work in the system. So up until very recently, they had a one physician per OR model. Most of those are FRCA specialists. They do bring in specialists from other countries through a pathway that used to be called a CESR, a Certificate of Equivalent Specialty Recognition, a licensing pathway through the General Medical Council, which is a national physician licensing body. You can apply to have your credentials looked at. They want you to have written an equivalent exam. You'll send in about up to 1,000 pieces of paper documentation from your entire career to show they'll assess it, identify gaps, and then you can fill in those gaps. And once you get your certificate of, they've changed it now to portfolio pathway, but when you meet their requirements, you can be admitted to their specialist registrar and work just like a UK trainee. For people who either go through the training system and don't pass the final exam or come in from another country and don't have the qualifications to meet that portfolio pathway, they have these staff grade doctors. And staff grade doctors work clinically in many centers. There were surgical staff grades. They exist in all the specialties, but they exist in anesthesia as well. And so they will practice, they will give anesthetics, simpler cases, some supervision, but they are, workhorses of the UK system in terms of some of the anesthetic care provision. And then they also utilize their trainees. So they train for a lot longer. They write their Royal College exams in third and fourth year. And then in the final years of their residency, they will work independent lists. With supervision, there's always people nearby, but they will be assigned lists to work independently. And from what I understand, most of the after-hours work is still being done by senior registrars after hours. That has not changed. From an anesthesia support model, if anybody working in the UK or come from the UK would be familiar with the concept of an ODP, which is an operating department practitioner. And the closest thing I've found in Canada is an anesthetic tech, but they are people that are hired into the healthcare system. They do a 2-year degree straight out of high school, and they work in operating rooms and recovery rooms, and mainly in anesthesia support. And I think for people who work in the UK, they can't imagine practicing without them. They seem to have a sixth sense about what everybody needs before you even need it. And they're a really important part of the perioperative pathway. Their salary ranges from 28 to 43,000 pounds. They're available after hours. Most centres wouldn't be operating without an ODP on site. They manage all the equipment, all the machines, all of it. The UK released the Royal College of Anaesthetists released a State of the Nation in 2022, which is a really long, fascinating document. I've included the QR code if you're interested. They have severe workforce problems, and they're anticipating that by 2040, they will be 11,000 anesthesiologists short. They have some morale and retention issues, especially for some of the younger trainees and staff who have left for other countries. And then they've had high rates of retirement. Add this to the increased anticipated need given the aging population, and they are anticipating to be really, really short, which, I think we are as well. We just haven't been able to nail down these kinds of numbers because we don't have national workforce data the way the UK does. So as part of recognizing that this is a problem, they've had these anesthesia associates since 2004 in a sort of ad hoc way in a few centers across the country, some of whom were doing lists under supervision independently for more straightforward cases. But since 2017, it's been progressively growing. So they now have, by 2022, they had 160. And then as part of the NHS workforce plan, they're aiming to train 200 per year over 5 years to build the workforce up. And they are working in a 2-to-1 ratio with staff. So the people that they're taking into the program are people with either an undergraduate degree or who have been working in the healthcare system and have at least 3 years of healthcare experience. So there's a sort of a clinical pathway or an academic pathway into the program. There are 3 centres in the UK that are offering this program, Birmingham, Lancaster, and UCLH. The program was just getting going when I was there in 2017, and they have recently had to put their recruitment on pause, and this is related to issues from the college. So they've currently paused. They had a plan to create a proper regulatory framework and continue recruitment, and everything has been paused at the request of the college while they review the evidence that they have and ensure that it's safe. The trainees in anesthesia have been particularly vocal about their concerns over this model because of a lot of the morale problems that they have and access to lists and whatnot. They are moving forward. They anticipate that the licensing and the program will get going up again by the end of the year. The UK has come out with some pretty innovative models. If we want to talk about other forms of innovation, about how to tackle surgery waiting lists, this one is one we've actually adopted in Ottawa, the HIT list. So they call them high-intensity theater lists. And this is a way of using one anesthesiologist and really expanding what the work of one anesthetist can do in the day. So you have one anesthetist. In Canada, in Ottawa, we have one anesthesia assistant and an extra nurse in the room, and they go back and forth between rooms. And the idea is to cut out the turnover completely. So it only works if you do short cases, generally we say 1.5 hours in duration. Otherwise, there's not enough turnover saved to justify the extra resources. And it's a perfect anesthesia care team model. It gets a little bit funny because different hospitals have different rules about what anesthesia assistants are allowed to do. In some hospitals, the AAs can't extubate, but they can take out LMAs. In other centers, the OR nurses, the PACU nurses will extubate. But in general, the idea is that as soon as one case is done, the next case continues. There are models like swing rooms that are done under regional or spinal, same thing. As the rooms are closing, the anesthetist goes over to start the next case while the AA finishes. They've gotten a lot of positive PR for this, and it's been a success for us at the Ottawa Hospital as well. We've been doing it for the last 2 years. All right, Scandinavia.
So Scandinavia presents a really interesting model as an alternative. It's kind of like looking at a parallel universe to the US model. So Scandinavia has a team-based, so Scandinavia, the term I think most people understand, I don't need to get into it, but it's all the Nordic countries. So team-based, led by the anesthesia physician. It's almost like there's a team huddle ahead of the theater list, the OR list, to talk about who's going to do what, and to assign cases appropriately, to look at how to collaborate, how to get the entire workload done, whatever their planning cycle is, if it's a day, a week, a month, doesn't matter. So what is this system? In 2010, the Scandinavian Society of Anesthesiology and Intensive Care put out a paper, and they re-endorsed the model, saying this is the model that the prior 50, 60 years has evolved. It needs to continue in all Scandinavian countries. They're very happy with it. They're very happy with the outcomes and what it's done for their resources. The 2010 data is there's 3,800 active specialists and 1,270 trainees in Scandinavia overall, but shortages are anticipated, both for MDs and RN providers. Next slide. What about the nurse providers in that? So the breakaway, the divergence in the nurse care models from the US couldn't be more stark. It has gradually evolved directly under the supervision of the MD anesthesiologists. It has taken a completely different direction from the US. There is amiability, collegiality, and cooperation leading this model. The ASA 1 and 2 elective lists are typically the ones that the MD might delegate to the nurse anesthesia provider. Say, okay, go ahead, run with this. This is what you do for the coming day, week, month. And if there's a 3 and 4, or there's variation in between of complexity, then it will likely be still the nurse anesthesia provider who's in the room, but it is under the direct supervision of the MD anesthesiologist, who may be going back and forth between 1 or 2 rooms. ASO 1 to 5, that are acute urgent, is always in collaboration with the MD. So in essence, the MD is responsible for all the planning and the management and the plans that are put out. The local and regional cases are pretty much independently monitored by the designated nurse providers. The training and practice endorsed by Anesthesiology Society and national standards for safe practice. So there have been multiple documents that have been put out, both by the nurse practitioner bodies and the physician provider bodies, to say this model works, it's safe, this is the one we want, let's continue it. Next one, please. Okay, so what is the intake pool, and what do you have to do to become a nurse anesthesia provider in the Scandinavian model? You need to have a minimum of 18 months of full study time. And quite a few actually end up doing master's level thesis or thesis level kind of achievements within their training. It's a full-time training. It's often paid for by the hospital that's recruiting those providers. And the extension is to 24 months if master's level does happen. The popularity you can gauge by the fact that even with the limited population that Scandinavia has, there's nearly, or not nearly, there's a very high ratio of positions available to applicants. So on average, 30 applicants to each position available. And they're pretty high job satisfaction ratings. What are the, what's that?
I spent one step ahead of you.
Yeah, wonderful, thanks. Okay, the benefits of the Scandinavian model. So less contention, if any contention at all. There is the team-based approach, which is truly team-based. Those of you doing huddles in your ORs in the morning and talking about, okay, how we can do this, surgeons there, anesthesiologists there, it's pretty much the same idea. You get together, you talk about what is appropriate, what is designation is appropriate, what scope of practice is appropriate. And then supervision ratio flexibility, I haven't heard from any of the people that it significantly goes beyond 1 to 2, but there is a flexibility in there. The position papers actually clarify that as well, but usually it's a 1 to 2 model. The physicians, so there's an interesting comparison of feedback by physicians, nurses, and trainees in this model. And the physicians who are part of this feedback are saying, we've got the flexibility to go help another physician, a trainee, somebody else, because we have a nurse anesthesia provider in the room with us. So I'm free to move around and help out wherever I'm needed. They really like it, and they like the collaborative aspect of it. The nurses are saying, this is a really good thing for our career satisfaction. We feel empowered, we feel supported. The trainees are saying, it's great because I can go from room to room depending on my education needs. If the need is I need to see 2 blocks being done, nerve blocks being done in some other room, I have the flexibility because there will be the nurse anesthesia provider there, and then I can go to the other room and carry out those training experiences that I need. Outcomes, probably as good as anywhere else. There is no difference reported in patient outcomes between Scandinavian anesthesiology care or anywhere else. Excuse. Okay, so this is the WSA workforce model that didn't quite come through, but the...
No, it looks better on the big screen.
Yeah,
can
better
see
on the
it.
big screen? Yeah, okay.
Yeah.
So the colored areas are the one where there is some element of nurse anesthesia provision, and those are the countries. So it's not an isolated Scandinavian or US thing. It's in quite a few countries. Okay, next one, please.
Yeah, I think also there are countries here that we just don't have the data, but probably
Exactly.
do have some non-physician providers. Just I couldn't get that from the WFSA map.
Okay. So before we leave Scandinavia, there's some drawbacks to that as well. So not all cases will be appropriate for all providers, that they're careful about it, but they're also talking about risks to the system. They have shortages happening, they have sometimes contention happening, so it needs to be carefully handled. Australia and New Zealand. So Australia and New Zealand are probably the closest to the Canadian way of practice. It's physician-led, physician-based. And IMGs are a significant part of the workforce itself. Now, when you look at the Australian model, the ratio can vary extremely widely. I think it's similar to Canada in that respect as well. So the major metropolitan urban centers, they'll have a lot of providers of anesthesia, physician providers. You step outside, rural Australia it's all over the map. And sometimes it's the same ratios that might be found in very low-income countries. So Australia has had the need, but it seems like a pipeline is developed, and Sylvie did some research into that. The UK exodus that's happening of anesthesiology providers, physicians, Australia seems to be the main beneficiary. So there's a pipeline there to Australia, and they're actually projecting, the Australian anesthesiologists at least, a surplus by 2025. So yeah, that's something to consider. New Zealand, on the other hand, is facing far more challenges. They're really going out and advertising for importation of physician anesthesiologists or other providers. And their rural service is by enhanced scope provision by a physician who's family medicine trained, similar to Canada. And the innovations that are there in the US, the Australia and New Zealand model, is I was talking to their previous head of specialty society in Australia, and he's saying that there is a big impetus and some examples of train to retain. So they're doing their best to train according to the jurisdiction that needs. They offer up a candidate, they get trained there as much as possible, they get retained there as much as possible. Next one, please. Okay. And these support models there for a 2-year degree, assistant for the anesthetist, this was put out in 2016. And the prerequisite is a bachelor's degree, and it's similar to Canadian anesthesia assistants. The model in Japan, the trend that you will find in the next few slides is all these countries are looking to the West. What's working for you? What's not working for you? And they're very interested in the non-physician anesthesia provider model, especially not the nurse-led one, but the certified anesthesiology assistants or whatever anesthesia associates that they may be called. So Japan has a lot of physician workload increases lately, and burnouts are a major concern. There are no alternative providers. They have nurses. Nurses assist them as the anesthesia assistants assist us. Okay, next one. China, very interesting example. You go to Beijing, the ratio is the same as in any developed Western country. You step outside of Beijing and the major cities, it plummets. So it's approaching very low and middle and lower middle income countries. So there's only about 5 to 6 providers per 100,000 population. Again, China has a physician-based model. The nurses provide assistance to the specialists, but they're already talking about the very low pay, very high workload, high burnout rates, and whether they can look and benefit from some non-physician provider models. Next one.
Yeah. The other interesting thing about China is that they have different levels of training, right?
Yes.
They have a 3-year and a 5-year training.
Oh yeah,
program.
I forgot about that. So that's a really important thing that we may want to consider, which is you can train for 3 years and you become a regular provider of anesthesia as a physician. If you want to become an associate head or the head of the department, I don't know what those responsibilities are. It seems like they can do more complicated cases, and they actually get to supervise the other quote-unquote regular anesthesiologists. If you want to get into that category, it's a 5-year training. So 3 versus 5. 2 models of training are actually available as well. Thanks for that, Sylvie. India. So the density overall is woeful, as it is unfortunately for a lot of countries that are in the same boat of being lower, or actually India is climbing up there economically. So, but this is a paper put out in the Indian Journal of Anesthesia that highlighted the disparity that is across the country. And they are very much interested in the 2 concepts of task sharing and task shifting. So if you aren't familiar with those concepts, I would encourage you to get familiar, because those are going to be the part of the conversation regarding each HR model, no matter where it is. Task sharing is doing the same thing together, or doing the same thing in separate groups. Task shifting is you delegate some particular task to somebody else. Task shifting becomes even more important when you are in the low middle income and the lower income countries. Okay, next one. Current states and innovations. So these are pretty much the models that we see across the world, and then there's statements by WFSA, WHO, which is saying that if you have less than 5 anesthesia providers, doesn't matter physician, non-physicians, per 100,000 population, you are not meeting the standard for anesthesia care. So you really need to go well above that, and countries are struggling how to go there, and they're actually referencing these WFSA and WHO statements in building their anesthesia care models, okay? And the provider models, physician, non-physician, we just heard about that.
Sorry.
So that's good, no worries, we can advance. You're actually thinking my thought.
Trying to
So
anticipate.
BMJ Open, talked a little bit about very interesting care model provision example. This comes from MSF, Doctors Without Borders, and they utilize either physician providers. Their preference is to have physician providers when they can. They'll next go to nurse providers, and they'll last in active conflict zones, at least. They will go to uncertified providers. So not sure what the training is, not sure what it is, they're just doing it. So what they found is, if they do a team-based approach to it, almost always led by a physician, nurses are sometimes there, sometimes not there, and the uncertified ones are sometimes there, sometimes not there. Overall, and it's a healthy population that they look after. So it's 24 to 27-year-olds that were included in this study, and they were all healthy. So 0.2% mortality in the healthy population. So there's some numbers we can hang our hat on. Okay, and the next one.
All right.
Okay,
Me?
over to you.
Thank you. I thought we needed to spend some time talking about non-operating room, non-OR anesthesia, or out of OR, used to be called remote anesthesia, because this is a growing part of our practice. And we've stolen a few of these slides from the ASA task force on HR because you can't improve on perfection, I think. And they published a paper in 2017 looking at the increase in the out-of-OR work for anesthesiologists. So in 2010, it was 28%. In 2014, it was 36%. And by 2023, it's estimated to be at over 50% in the United States. I don't think we're there in Canada, but our center is certainly feeling the neuroradiology, the interventional radiology, the increased demands for sedation for complicated patients in other parts of the hospital. And if anybody attended my 5:15 graveyard shift talk on Saturday, thank you, because it wasn't the best time slot. Cataracts continue to be a big part of our work here across the country in many centers. There are some institutions like Cleveland Clinic who have tried to standardize their approach to how they provide out-of-OR anesthesia, both to improve patient safety, but also to improve the efficiency, because in general, these are not really efficient lists. There are a case here and there, they're half days, and they've really tried to take a scientific approach to how to do that. And speaking as an ex-site chief who tried to lead this at my own hospital, it is incredibly challenging to work with some of these subspecialties and areas and try to explain to them why they need to change the way they do things, because it's always, they really like the convenience of being able to call us in whenever they want. This is another ASA slide. So in the US, they do about 100 cases a year. We need to, and there are some cases that we need to be there for. There are some cases that we might need to be there for. And how do we find that overlap, figure out what that is? I think that in this current HR climate, we really need to think long and hard and be systematic about our involvement in sedation cases. So I've worked in many centers across the country. It is actually shocking the variation of practice that exists. So cataracts, endoscopy, even things like radiofrequency ablation, lithotripsy that are done with an anesthetist all day, every time in one center, and there's another province that they're never in that. We're never in those lists. The sedation is being provided by nurses safely with the same outcomes. And so I have a really hard time with that. I have a hard time wrapping my head around how we continue to provide light sedation in some of these lists. And you may have heard me speak last year at the conference about this. It's a subject that I'm pretty passionate about. An anecdote, I was having a really contentious meeting with an area of the hospital where we were looking to try to pull the anesthesiologists and move to a nurse sedation model. And we had enlisted the help of our hospital leadership. And they invited the hospital ethicist to the meeting, which initially I thought, wow. But actually he said, probably I learned more from him that meeting than I'd like to share with you. He said, the radiologist was saying, this is the standard of care. We need an anesthesiologist because it's the standard of care. And he said, I'm really hesitant to hang my hat, and I never really know what to say when somebody says standard of care, because there are all sorts of examples in our hospital where we are not meeting the standard of care. There are patients waiting a week for their emergency surgery. There are cancer patients who aren't meeting their targets. There are patients sitting in the emergency department. So to say that something is the standard of care is a hard pill to swallow in our current environment. And what we need to look at is where we can use the limited resource that we have to have the maximum benefit to the highest number of people. So on that note, I think one of the things we need to do is increase our pipeline, but we also need to look at where we are working and coming out of some of these areas where we do not absolutely need to be there. And without fail, every time I bring this up, somebody gives me an example of how they saved the day in one situation where they picked something up that somebody might not have picked up. And those things happen, but they happen without us as well. There are all sorts of places in the hospital where much deeper sedation is being given without us. So I think we all need to take this back to our own institutions and think about it to try to minimize the number of ORs that are canceled, because those are places where we do absolutely need to be. All right, traditional anesthesia models.
Okay. So I think the Canadian system is pretty well known. We wanted to leave at least half an hour for discussion. And that is the prime objective here. So I think we'll stick to that. We'll go a little bit rapidly through the rest of the things. We'll make a closing statement, and we'll be right there. We're doing okay.
We're doing well.
All right. So let's kind of get, so one model. One physician provider, one surgeon, one patient, one location. That's the typical model. And the sedation providers vary all over the place in Canada. Okay, go ahead, please. Next.
Okay.
So where do we work? If you aren't familiar at all with where anesthesiologists work, and if there's some people who want to refresh their memory, it's not just the OR. It's everywhere. Okay, so, and next one.
One comment on this is that we've been under a lot of pressure at our hospital, as I imagine many of you have, is to pull our anesthesiologists out of these non-OR environments to bring them back to staff the operating room. So come out of chronic pain, come out of APS, and I think that's a really short sight. I know there's some opportunities for efficiency, but I think that's a very short-sighted decision, and it's not something that we're encouraging today.
Yeah, all of us are struggling with that. And they may, if we do these postponements, deferrals on a regular basis, and a lot of these come back to an even more prolonged waiting list on surgery. They directly impact surgical times as well. The physician workforce model, Sarah Simkin et al., published in 2023 in Anesthesia and Analgesia, they've shown that we are currently sitting at about 3681 physician providers, and this includes 536 FPAs across Canada providing service. Our ratios are just around 10 per 100K population. The workforce has gone up by 1.8 times since 1996. So to 2018, this is the increase in the workforce. It's predominantly male still, but the gender balance is improving. The international trained physicians, IMGs, constitute about 30% of the workforce. In the rural areas, it's closer to 40%. The rural service provision is primarily by FBAs. Average, okay, I don't know what to make of that one. Okay, 2.3. Yeah. Yeah, I think we needed a light moment there. The increase in age of the provider, they're putting in the work pretty quickly. Huh? So average has gone up by 2.3 years. The annual retirement rate, and this is pretty important for us to recognize, it's about a 3% attrition rate from the providership, but the rate is about 2 to 3 times when it comes to our FBA colleagues. They're just facing a whole another set of challenges. Next one, please. Okay, anesthesia assistants.
With anesthesia assistants, they exist in most provinces. There is variation by province in terms of their regulation. In some provinces, they're not regulated. In others, there's a difference in the tasks that they can provide. There are 6 programs that train anesthesia assistants. You can be either an RT or an RN. The large majority are RTs, but I have worked with a few nurse anesthesia assistants in my career. And CAS, ACUDA, everybody was involved in developing the framework for them. Respiratory therapists, they can do either a college diploma or an undergraduate degree, depending on where they're training. They provide a lot of perioperative procedural support in some centers. And in some provinces, they are licensed to relieve anesthesiologists. And they do light sedation without us. Like in some hospitals, the RTs are working in the endoscopy suites independently under supervision of the surgeon. The OR support, the OR nurses are still very prevalent in many centers. Their training and their tasks vary dramatically depending on where they're working. In some places they set up equipment, and others they don't have anything to do with that. And we're seeing a gradual replacement of OR nurses by anesthesia assistants in many centers. The anesthesia technician program exists in the US, and in Canada, the main site is Halifax. And for those of you who work in Halifax, I hope you know how lucky you are to have these people working with you. So they train for 9 months. Right now it's a college program, and they learn all about how to support anesthesiologists, everything about equipment. They do all of the lines placement, all the machine checks. They can help you with all sorts of things. And having trained in a center with anesthesia techs, I'm a huge fan of this model, and I would love to see it expanded into other centers. I looked at it, bringing it into Ottawa. The problem is building a training program. So, innovation in Canada. Do you want to take this one?
Sure. Yeah. So, the sad part is there's not much innovation in Canada. So we haven't really looked at very different models. We haven't looked at other things that we might need. We're heading into an acute phase of gross critical imbalance between supply and demand. And what happens next is anybody's guess. Already in Canada, there are several examples of departments, provinces, jurisdictions, cities going ahead on their own by increasing ratios of provision. So 2 rooms are being supervised by 1 anesthesiologist. How it's being done, it varies. So we need to get ahead of it. With the innovations that we have done, we have come back to the older concept of anesthesia care teams, especially including anesthesia assistants. And we're having much more meaningful conversations around that concept. What does it mean? What does it mean to have a care team? How does it enhance the work, the workflow? So we are having those conversations. The transferring, so task shifting. So the task shifting of, let's say, provision of minimal sedation, cataract surgeries, et cetera. My own province, about 15 years ago, we stopped going to cataract rooms. We talked to our surgeons ahead of time. They do all the blocks. They identify those rare lists where they need us to be involved. It's still on our fee schedule, but we built the internal consensus that we did not need to be a part of it. There's been no change in either demand or mortality or complications that are related to that, as far as we can tell. Senior residents, now there's starting to be conversations about transition to practice residents. Can they run their rooms? Is it part of their scope? Is it part of their training? Is it appropriate? So at least we're having those conversations. The next one.
Yeah.
Okay.
This one's fine. So pre-op clinic. Pre-op clinic is another opportunity where we may be able to reduce some of the anesthesia hours required to run a pre-op clinic, and this is happening in other centers. At our center, we've worked hard to triage some of our lower acuity patients to nurse-only assessments. So there was a recent paper by Dan McIsaac and his team, I was part of it, looking at outcomes from PAU assessments on postoperative outcomes, and the patients that really benefit from it are ASA 3s and 4s only. And at that, the signal is not super strong, but at least it's there. And so ASA 1 and 2 patients probably don't need to be seen by an anesthesiologist. It becomes difficult, and we talk about the payment model, because those ASA 1 and 2 patients, I think we all know, are the ones that make the clinic financially viable, because you can, exactly, because those long, complicated cases take so long, and the fee codes are not that, don't necessarily reflect the amount of work that needs to go into those more complex patients. There are centers across the country that are introducing nurse practitioners or physician assistants in the pre-op clinic, either working under they'll see patients in the room next to you. And there are also places I think in Quebec especially, where they have family doctors still working in pre-op clinics, and I think that's something we used to see earlier and still exist in some centers, and they're asking us if it's something we'd like to think about doing again. Speaking from personal experience, the major challenge is not just the payment model, it is the administrative burden on the people trying to make the change, because these are really, really big changes to make in terms of how you flow patients through the system, avoid cancellations, and we don't all have that kind of time, most of which is not remunerated.
Okay, so I don't need to speak to the slide, but I'll just offer some closing remarks here. The old adage about if you're not at the table, you're part of the menu applies to us. It's a critical point in our evolution as anesthesiology leaders in Canada. We at the very least, we need to be aware of the different models that are out there. We need to be aware of the challenges that we're facing, and we need to be aware of the changes that have already started to happen, whether we as a National Specialty Society or leaders have participated in those changes or not. Local demands are driving those kinds of changes. So with this, the talk that Sylvie and I thought about how to frame it, this is not prescriptive, this is not proscriptive. This is not the official position of the CAS. This is a thought exercise which hopefully becomes a deliberate, conscious effort on our parts to say, how do we meet these ethical, service provision, legal, administrative, educational, capacity, and all sorts of other dimensional challenges that are facing us today. So with that, I want to thank Sylvie, a wonderful collaborator and partner, and I want to thank myself for having the courage to step into this conversation. Okay. A mic has been brought there. I would really encourage participation, thoughts, questions, whatever comes to your mind. The little housekeeping thing there is, the more the people that participate, the better. So please, if you have a question, frame it as a question. If you have a comment, frame it as a brief comment. Formulate the question in your mind before you step up, and I apologize, cut you off, okay? Because there are other people waiting to comment or to participate in the questions. So please do line up or get close over there, and let's start the conversation. We do have chat related.
Yeah, I think we'll start with some in-person questions, and then I'll
Is there anything there right
a
now?
little bit, yeah. But I
Okay,
think
sounds
we'll
good.
start here.
So go ahead, please introduce yourself and give us your comment.
Hi, my name is Puya. I'm from Ottawa. I'm a medical student. There is quite a bit of concern among my classmates about future job security in like the next 10 years. We do recognize the shortage and how we might have to eventually shift to a non-physician model, but if the outcomes turn out to be similar, especially for lower acuity cases or ASA1, ASA2 between like a nurse anesthetist and an anesthesiologist, and we're a publicly funded system, is there concern that maybe we won't have jobs in like 10 to 15 years?
Okay, so I have dealt with this question before, and I can give you a short answer because I think that should be, you have nothing to worry about. Okay, so based on the projections that are out there, the work will only keep on increasing, and we do not have enough providers. Alternative providers, if they are to come in, it takes time, effort, energy. Within your lifespan, professional lifespan, and within the next generations that we're training right now, everybody's job is there. Okay? Thank you.
Thank you.
I will say that maybe the job won't look exactly as it does right now, potentially. I think there might be some changes in terms of the tasks that you do, but yeah, I would 100% agree.
So, Dolores, before you go ahead with your question, I would also encourage people, I know Giuseppe's there and Nicola's there, so with the Quebec perspective, from an HR perspective, how you're doing, Quebec is a unique example in Canada. The HR projections and estimations that are done there, we can all learn from. Dolores, go ahead.
Hi, thank you. For those of you who don't know me, my name is Dolores McKean. I'm the past president of the CAS. I'm the Dean of Medicine at Memorial University. I just want to say to Mateen and Sylvie, thank you for an amazing talk. I think we kind of all have known that these little things exist around the country and different models, but I think you guys have done an amazing job putting it all together and giving us a really good overview of the pros and cons. Two things that I wanted to say. So as physician anesthesiologists, how do the providers that are doing the 3s and 4s all the time, working at the top end of the scopes of practice, how do we prevent burnout from that group, first off? Because for me, I mean, I don't mind doing a nice little API list or gallbladder list or whatever it is. And I think if I had to practice at the full scope of my practice all the time, I would burn out pretty quickly. So that's just one thing that I would ask. The other thing that I would ask, and people have sort of put this out to me, is there any appetite for ACUDA to think about, after you've completed your 3rd year of training, have some sort of, not wait until 5th year and transition to practice, but I think if you've done the basic of your anesthesia training, you've done all your core rotations, you would have similar or more training than an FPA. Could we not somehow get those folks some sort of community license where they could go and do some sort of 3-month or 6-month service provision? That would be tremendously helpful for them in terms of their clinical practice and would also be socially accountable to our rural communities. So just those 2 questions.
Dolores, thank you so much. Maybe I'll address your second question first. I think it's more of a comment. So ACUDA, those of you who don't know, Association of Canadian University Departments of Anesthesiology. So this is the body that represents all the chiefs, educators, et cetera, researchers across Canada. So I think that's, your point is very well made. and we all have to think about it. It may not be ACUDA's mandate. It's probably the Royal College's mandate. So having the conversations between the CAS, ACUDA, Royal College, getting the people together. Why don't we have a task force in Canada that has representation, that does iterative planning along those lines and has these discussions? Anything to add?
I agree. I've actually been asking that question. Are the RIPE residents allowed to be double covered? And I have gotten different answers from different people. The most recent I heard was no, but I had heard in the previous year yes. And what I heard in the end was as long as they feel well supported, it might be okay. I think the residents want it. Like our PG, we recruit into our programs some really phenomenal people. Like, you know, it's a competitive specialty. We're bringing in really good people. By the end of second year, they are able to provide a really safe anesthetic for lots of cases. And we might actually be doing them a disservice by not giving them the opportunity to do that.
I'm going to paraphrase your question for the virtual attendees. So Dolores has added to her comments and questions by saying that, is there a way to look at some kind of provisional status or licensing which enables such care to happen while they're still in training, but enough sufficiently prepared to participate? You had the first question. Do you want to, the first question related to preventing burnout, ASA 1, 2, 3, 4. So I will briefly share that the feedback from the Scandinavian system, at least, is that physicians are a lot happier. So they actually get to go from one place, one room to another, and they have providers who are taking care of the details. They can use their brain power to actually problem solve and guide the teams that are providing care. Anything to add?
Yeah, I mean, I would agree with that. I think for us in our center, one of the major sources of burnout is the lack of somebody to help you who knows what an anesthetic is. So it's possible that in these team models it may be reduced if it's done properly. I don't think if it's done ad hoc. I think if we take a thoughtful approach to this and we build a model that we can work within, I don't think it has to be. Plus, lastly, I find sitting in a cataract list, giving 0.5 milligram of midazolam while other lists are canceled, much more stressful than doing an open aneurysm.
But what I would say is that, and I'm sorry, I've got it, Mike, so what I would say is that's a little bit of a different model. So if you have somebody doing the 2s and 2s, you're doing the 3s and 4s. That's different than you overseeing all of them.
Yes. Yes.
With somebody helping you. Totally different.
Yes, you are correct.
You can't be in the room by yourself, keeping somebody alive 5 days a week.
Yeah. So Dolores just made a distinction between a model where somebody does 1 and 2, the other does 3 and 4, and the 3 and 4 person is going to get burnt out. Okay, yeah. So maybe that.
I feel like the people speaking up is the who's of the CAF.
Oh, there you go.
It.
I feel intimidated.
Yes.
Step forward, please.
Great.
I don't know if I'm a who's who yet, but thanks for that comment. But I'm Greg Manning. I'm the current CAS chair of the EDI committee, but I'm also now a senior medical director in the Newfoundland Labrador Health Services, so our new provincial health system. So this kind of stuff is my full-time job now. I'm really happy that you compared the other countries in Western Europe. I think there's a temptation for us to always compare ourselves to the United States, but it very much is an extremely expensive and a very underperforming system compared to a lot of Western Europe. So I was really happy to see the comparisons to other countries. I would like to ask you specifically about Australia because it is a country that is geographically similar, has a similar population, similar physician remuneration, but we have a huge disparity in terms of our anesthesia providers, despite you saying that our models of how we provide anesthetics are similar. So do you have any sense, or can you do maybe a little bit more of a deep dive, and maybe we don't know, of why they're having so much more success compared to us?
Yeah, and I looked into that. So, and Sylvie has good knowledge on that as well. So, I would say that if we give a similar talk next time around in Newfoundland, we'll have a lot more information. So we'll do a much better, deeper dive on the Australian, New Zealand models as well. Here's what we know currently, what I know, and Sylvie can add to that. they are facing the same challenges. Right now, the difference between New Zealand and Australia seems to be that Australia is attracting that pipeline of migration of anesthesiologists from UK and other parts of potentially of Europe. They were projecting shortages. Australia was doing that, but now they're projecting a 2025 surplus. Maybe that's the distinction. But when I talk to their leaders at the specialty society level, they're all saying the same thing, 100%. And this was maybe 2-3 years ago. They had exactly the same problems that we have. They haven't solved anything. If suddenly we had a full pipeline coming in, maybe we wouldn't be having these conversations so acutely. But that seems to be the difference. Regulatory perspective, they're probably a bit more nimble than us. So that can be a take-home point. From a regulatory perspective, we need to be more quicker at decision making. So there's, Dolores has her hand raised, recognizing that others are trying to speak. Yeah, fair enough. Thank you. Does that help address?
Yes, thanks so much.
Yeah, just be a part of the conversation, please. That's the only request. Okay, Stephen? Oh, sorry, did you have anything?
I'm going to wait. Just reassure the people at home we are going to get to your questions. We'll
Okay.
get the people who are.
We still have 15 minutes officially to go, so we did good. Well done.
Good one, huh?
In
Good time
timing.
management.
Okay.
And you haven't cut anybody off yet. That's great as well. Stefan Schwartz from UBC.
It might be you.
Yeah, I won't be surprised. Stefan Schwartz from UBC and St. Paul's Hospital, and I serve as your faithful CJA editor-in-chief. A couple comments. In my view, the most important slide that you showed, Mateen, was the one outlining all the different places where we work. And I often personally feel that this whole discussion is sort of a victim to a bit of a fixation error. A fixation error on provision of sedation or maintenance of anesthesia in the OR, which, as you showed so nicely, is just one of the many places where we work, as well as a fixation on safety. And sort of from a statistical analysis, study design point of view, well, what is the incidence of avoidable intraoperative death? What is it? Maybe 5 in 100,000, if it's much. So if we were to show, as Daniel Sessler in his June 2024 anesthesiology editorial, which was a written version of his Rovenstein lecture at the ASA meeting, showed, let's just say we wanted to show a difference in safety between 5 in 100,000 and 10 in 100,000. You need to do a study with 1.5 million patients. So I think we need to move away from that. It's a rare event. Things have gotten incredibly safe, and I would echo Dan Sessler's call for focusing on our identity as highly educated specialty and subspecialty perioperative physicians.
Yep.
My second comment, quite independently, was that regarding residents. It has struck me, and perhaps from a slightly residually biased European perspective, if you look at continental Europe, then in most countries, senior residents run the rooms, and that's in Germany and Scandinavia, France, what have you. And again, safety, there's no numbers, including for reasons that are outlined to support that. And it has struck me that in Canada, I think it's also interesting to look outside of anesthesia, because this sort of model of one attending, one resident, one patient, we don't find that in other specialties in this country. And I'm always amused to see the ICU run in the middle of the night by an R2 in psychiatry. So just a few comments.
So, Stefan, thank you so much for those comments. Stefan, why don't you stand for just a second? You don't need to go back to the mic. I just want to use the opportunity to recognize the incredible work that has happened by our CJ editors. Hillary was there before, Stefan is there now. CJA is a major dominant force in anesthesia literature now, thanks to the efforts that have been made, and we are part of the conversation. Please applaud those achievements. Thank you so much. Thank you very much. So,
I have nothing else to add. I think you've summarized. I don't have anything to add to that. Other than that, I agree wholeheartedly.
I also agree, and I think participant to these subsequent conversations should be CJA. okay, and the editorial staff. You have a lot of wealth of expertise, and we need to be able to utilize that in these conversations. Thank you for that. Giuseppe, if it's okay with you, can we take a virtual inventory, see if there's somebody waiting?
Sure.
Okay, yeah.
It's a long one, so I'll paraphrase. Canada is home to thousands of IMGs, which is a potential workforce, not just for anesthesia, but other disciplines. It seems impossible for them to find work, and even in categories like physician assistants and associate physicians. How can we put their skills to good use? It is a shame that they're working a non-medical job when there's a shortage. I actually, if I could go back to the UK slide, they've had an interesting approach in how they bring IMGs in, right? So the highly trained IMGs where the training is comparable and they can demonstrate that, have been able to join a specialist registrar. We have not had much success with that because we don't have a national licensing system. That would be, and I've had conversations with Verd Naik, who was one of my department members until very recently about that. I think the staff grade model is actually being explored, or some version of it in the Maritimes. So in Nova Scotia and New Brunswick, they do have a long history of hiring physicians who can't be licensed to work in Canada independently as clinical associates, is what they call them. And we haven't had them in anesthesia, but they exist in cardiology and ICU, and they're basically working as permanent senior residents. And many of those have tremendous job satisfaction because they're working at least in the medical field, they're making a reasonable income, more than they would be in a non-medical job, and they're able to contribute to safe provision of care in many specialties. And I think this is something that's being explored for anesthesia. I don't know if that's official, but I know it's been talked about, and maybe it needs to be talked about more and expanded into other parts of the country.
Thanks. Giuseppe.
Bonjour. Je vous faire parler en français? Non, c'est correct. It's fine.
Oui.
I guess for the benefit of the room, I think it's better if I ask in English, but if you want to answer in French, no problem. First of all, great presentation. So I think that really there's a lot of food for thought there, and I think you're going to spark something that will definitely start like a conversation that perhaps we should have started a long time ago, and that will definitely have an impact, just on the CUDA there, but even on our board and everywhere. So this is something that we're going to have to discuss. I know that you mentioned what's happening in Quebec. Nicola could tell you about it, but I mean, I'm on the mic, so I might as well talk about it. Like, as Sylvie knows, we have RTs, just like they have in Nova Scotia. So as the same modeled the same way, where we have one per room, and that helps us tremendously. But we also feel the crunch in terms of numbers. There's no doubt about it. I mean, you already know. I mean, I presented last year at the President Symposium on the way we cover rural areas with our program. That seems to be working very well. But obviously, with our numbers, it might become a little harder to cover areas. One thing I'd like to mention, though, and that's perhaps not necessarily our fault, but our legislators is. It's also been cyclical, this kind of like physician shortage. You go back to the 90s, it was like no anesthesiologist. We started training a lot of them, and then we went up, then back down and back up, and now we're increasing our cohorts again, and chances are that in 4 or 5 years, we'll see a difference. Maybe not enough to really compensate for the extra work that we have in migration and so on and so forth, but it's something that definitely is going forward. To answer your question, I don't think you'll ever have to worry about work. That's for sure. I mean, and there'll always be work for a well-trained physician, no matter what. So it doesn't really matter, but just like Sylvie said, definitely that your tasks might change over time, but definitely that this is something that you shouldn't have to worry about. And that's pretty much it. Again, thank you, and we'll probably have to have a talk about this eventually, and even perhaps include something at the next meeting next year, where perhaps we can continue this conversation. I think it'll be important.
Absolutely. So Giuseppe, while you're there, those of you who don't know it, Quebec is sort of leading the nation in this iterative HR planning process that we all should be engaged in. This is a model that I have explored with leaders in Quebec before, and I would encourage everybody to look at it. And if you haven't seen Giuseppe's presentation at last year's CAS, see if you can get a hold of it. There's lots of good learning points there.
Yeah. It's impressive.
Yeah.
Thank you.
Thank you, Giuseppe.
We'll hold you to that. Yeah, I mean, one of the things that we've talked about, because we've met often in preparation for this talk, is the need for a national task force. I know BC is trying to do it, Ontario is trying to do it, but is this an opportunity for us to look at this at a national level through our national society, and where are there opportunities to bring the anesthesia workforce back to where they need to be, and what are the opportunities for bringing in international providers. And we do not have, and Bev Orser and that Simpkin paper, we've tried to get a good handle on the numbers for our HR, but we don't really have national HR planning, which is hard in a patchwork system with 13 different jurisdictions, but I think we're paying the price for that now.
Amen to that. Yeah.
Hi, Raisa Petru. I trained in Halifax, and I work about an hour away from Halifax now. So a comment and a question. My comment is that with respect to what Dolores was saying, we allow residents at the end of their 4th year and in 5th year to locum, provided they have permission from the program director and a supervising physician, at least in Nova Scotia. I don't know if that's the case in other provinces. So I would think, what you were saying would be technically feasible as well as safe if we feel that they can locum. My question is with consideration largely pushed by government because of need for providers, consideration of introducing other providers such as AAs, techs, these CAAs that you spoke about. How do you ensure that the scope of practice is clear to both government and public? And that doesn't change with time, because the government is always looking for the cheapest option. And the problem, I think, with saying, they're all equally safe or the studies don't show a difference, is that I think part of that is we have made anesthesia so safe now that you need, to conduct studies that are, just so large that maybe it's not feasible. And, as I was discussing with someone else, death isn't the only outcome, patient satisfaction. A lot of what we do is, it looks so smooth because we've thought about all the problems and planned in such a way as to avoid them. So I think those kinds of things are hard to show. And I recall, I believe it was last year, the ASA president spoke about this as well. But yeah, how do you ensure that the scope of practice is clear to government and to the public and doesn't change with time?
Thank you so much for that. Sylvie, do you want me to start off? Okay. So, sorry, didn't catch your name, your first name?
It's Raisa. My last name is Petru, Dr. Petru.
Okay, Dr. Patrick. Dr. Patrick made a really important comment as how do we ensure appropriate scopes of practice? So one can talk about that quite a bit, regulatory, culture, pressure. To me, what stands out in comparing the international models is when you build a collaborative model, that is less of a problem. When you build a contentious problem, it becomes suddenly bloated. So the US CRNA versus MD, that is a contentious model. The Scandinavian nurses, again, working with MDs, that is a collaborative model. So the short answer there is the system design influences that the outcomes the system will have. So from my perspective, leading it, all of us here, we are the leaders to do this. If we build a collaborative model, we will have much less of a problem there. But is it ensured? No. There will still need to be insight and collaborative design around how to ensure appropriate scopes. Problems will never go away. Engagement ensures that we continue to address them. Thank you for that question. Anything to add?
No, but I'll read up a couple of these statements before there actually is no questions, just a couple of statements. Thompson Rivers got my AA degree, no longer allows IMGs, even foreign trained anesthesiologists, into their program. We have several IMGs who are fully trained anesthesia providers in the country tell me that the training was not the same and they didn't know anything. I think that speaks to the importance of a good process for assessing these patients, these practice-ready assessments and whatnot. And many IMGs have passed the MCCQE, would be qualified to apply as associate physicians. There's a requirement for currency of practice within 5 years. So, yeah, those are barriers.
Valid questions and valid observances. Go ahead, please.
Yeah. Hi, I'm Patricia Johnson. I come from New Westminster. Thanks for a great talk. And the CAS president, not CAS, CMAJ president comes from my hospital, and she says national licensure is it's coming. It's not coming as fast as they thought, so maybe that will help. But I had a question about liability. One of the things you didn't touch on was liability. How is liability dealt with in some of these different countries? When you're, giving a lot of responsibility to people, is the liability being shared equally? Or is it, physicians, are we still going to bear the brunt of both the cost and the outcome when something happens? Is it still going to come back and, it's going to say you were the problem?
Yeah.
I mean, I guess from a regulation standpoint, people have responsibilities, and we have many instances where, there's been a negative outcome, and not the physician has been held accountable for a nursing error or a system error or whatnot. So it's a good question, and we need to build a system that addresses that issue thoughtfully so that it's clear who has what responsibility and what your responsibility as a remote from a remote supervision standpoint is. And some of this exists already in the CAS guidelines when we talk about anesthesia assistants, and it would certainly need to be expanded if we do move to a different model.
Yeah, I think you're right. So you raise a very valid framework question. How do we build those frameworks and common understandings? So I would say that our perception, I would maybe channel my Stefan Schwartz a little bit in saying that, are we focused on the right problem? Okay, so we inherit this huge overriding concern about legal liability from the US models. There's just so much litigation going on there. So the two terms that come to mind that help build the right model are entrustability and scope of practice, and perhaps the third, accountability. So if the task is clearly defined, which means scope of practice, did the individual practice within that scope? And if they didn't live up to the expected standards that they were trained for, well, they are responsible. Litigation is much less of a concern around the world than it is for US and possibly even for Canada. But your point is very well made. Thank you for that. Yeah.
Are we done?
No, we have
one more time?
Yeah,
Okay,
we have
perfect.
maybe one more question. So Nicola, please go ahead.
Thank you for this great presentation, and I think we should reflect on that until next year. We are facing the same challenges in Quebec, although our model is a bit different. My question for you is, we realize that we'll have a lot of work, but there will be other challenges with healthcare professionals as well. So nurses will need nurses as well. So will they be able to catch up as well as us?
Yeah. So maybe a closing comment from you.
I mean, I'm not responsible for nursing human resources, but I know that at our own hospital, there's been a lot of, in Ontario and in Quebec as well, they've been quite innovative in trying to address the nursing HR issues. So, I mean, our hospital hired 75 OR nurses and trained them in-house, created a new in-house training program. There are alternative models in the nursing world as well, these operating room techs, some of these new programs that have been created. I'm not sure that the nursing profession is going to look the same in 20 years either in terms of the division of tasks. And so I don't have an easy answer other than I would rather we not be the problem.
Okay, I think that's the perfect note to end. Thank you so much. Thank you, everybody.
Thank you again for both of you for the excellent closing sessions. And we hope you found this year's program valuable. And this concludes the 2024 annual scientific meetings. Please exit the exhibition hall in the foyers to enjoy some sparkling wine and some bites before exploring the Victoria and heading back home. And we hope to see you next year in Newfoundland. Thank you all of you.